And welcome to our spring semester virtual event series of Benjamin Rush Institute. My name is Cleumy Gama. I'm a medical student from Liberty University College of Osteopathic Medicine, and I'll be your host for this evening's program. Tonight, we have the pleasure of introducing and chatting with Dr. Brian Flynn. He received his Bachelor of Science in Electrical Engineering from the University of Rochester and his Doctor of Medicine from the University. He completed a residency in urology at Geisinger Medical Center and a fellowship in female urology and reconstructive urology at Duke University. He's board certified in urology and female pelvic medicine and reconstructive surgery. Dr. Flynn has been a faculty member of the University of Colorado School of Medicine since 2002, and currently is the fellowship director of reconstructive urology and professor of urology and surgery. He's a national leader at his field and everything that he does. And most recently, since 2021, Dr. Flynn has generally shared his time with the Benjamin Rush Institute as a mentor for pre-med medical students interested in pursuing similar careers in surgery, with a special interest in first-generation students. So without further ado, Dr. Flynn, please take it away.
Well, thank you, Cleumy and Christian, Richard, and the Benjamin Rush Institute. This is my honor to be here with all of you, and this is meant to be an educational and interactive session. So please ask questions through the chat, and I look forward to spending time with everyone and learning more about this group and this society. So this talk, the title is something that the Benjamin Rush Institute asked me to give, called Physician Autonomy in the Hospital Setting. Having been a physician my entire career in the hospital setting, I think I'm well prepared to speak on this topic. As they mentioned, I'm a physician at the University of Colorado Hospital. And tonight we'll go over a little bit about who I am, talk about autonomy, talk about hospital employment. We'll go through some questions that the BRI posed to me, and then talk about some future directions. So as it was mentioned in the introduction, I've been familiar with the BRI now for about a year, and I'm really excited to get more involved in the society. There's no local chapter in Colorado, but hopefully some students in Colorado are listening, and there may be an opportunity to start one on our campus. My pathway started in electrical engineering, and I think that was partly because I really didn't have good mentoring growing up. I had no one in my family who was a physician, no one who was even a nurse. The amount of guidance I got in high school, I went in and saw my high school guidance counselor and said, "What do you think I should major in college?" And he said, "What are you good at?" And I said, "Shouldn't you know that? Like, my application's right in front of you." And he said, "Oh, you're good in math and science, so why don't you go into engineering?" And it was really that simple. And I was halfway through my undergrad when I realized I still had that calling to go into medical school. And I really think for those of you that are going in medicine, it really has to be a calling, because it's such a tremendous amount of time and work that you put into that. I went to Temple University, which is in Philadelphia, PA, and spent 4 years there. Growing up in Pennsylvania, I wanted to get back to my roots. Geisinger Clinic is one of the biggest medical clinics in the state of Pennsylvania. It's in central PA, not far from where I grew up. I did a fellowship at Duke University. For the students, a fellowship is additional training after your residency. It's not required. I could have went on and practiced urology right after finishing my residency, but I wanted to have some subspecialty training. And a lot of physicians that work in the hospital setting do have additional expertise and become very specialized and often practice in pretty large urban areas. I moved to Colorado in 2002, where I've been employed since. CU Medicine is the name of our physician group, and I'm double boarded both in urology and in female pelvic medicine. So I threw this slide in here just to recognize the Benjamin Rush Institute, which is named after the great physician and healer Benjamin Rush, who was a physician in Philadelphia, where I went to medical school. So there's a special connection there. And he was involved with John Morgan and William Shippett in founding the first medical school in the United States at the University of Pennsylvania. And he's a great example really for all of us and for the Institute, and someone who was involved both in medicine and then involved in his community. He was a well-known abolitionist in Philadelphia and really fought for the underserved people. And I think he's an inspiration really to all of us. So I'm really excited about the Benjamin Rush Institute and what the Institute is really starting to do to reshape medicine. Marcus Welby, I don't know if anybody really knows Marcus Welby. I barely know Marcus Welby. I was born in 1969, so this show was popular in the 60s and then into the early 70s. And Marcus Welby was sort of the quintessential family physician at the time. He was a great example of what a physician should look like. He had an unorthodox style of treating patients in that he treated his patients like family members. He'd often be on a first name basis with his patients and really, went all in as a physician. It was really who he was. He saw his patients both in the office as well as in the hospital, which is unusual these days. So I wanted to cite him as an example because for the students in the audience who go into primary care, many of them will practice just in the outpatient setting or just in the hospital. Family physicians tend to go both from the hospital as well as to the outpatient setting, as do most surgeons. The physician in the lower corner was his younger colleague, Dr. Kiley, who had a much more traditional way of practicing medicine. So that's unusual. Usually the older physicians would practice the traditional way, and the younger physicians are the trailblazers. And in this series, at least made for TV, it was the exact opposite. But they always treated each other with mutual respect, which is, I think, what we really need to have between those that are hospital employed versus the physicians who are employed in private practice. And together, I think we can make a big difference in patients' lives. So I just Googled this just for fun today, looking at the best doctors of all time in TV series. And this is a picture from ER, which was really popular in the 2000s. And ER is a show about physicians in the emergency room, both newer physicians as well as more senior physicians. And granted, this is a made-for-TV drama, but I think for maybe some of the older people in the crowd, this might be their first experience with TV medicine. This website I went to ranked the top 40 shows, and I did this just to show you a little bit of history. And over the years, physicians have always been very involved in medicine. And going through a number of great series. Grey's Anatomy, I think, just finished its 20th year. And even other shows that maybe weren't physician-based still had physicians that were a big part of the show, like Star Trek. So I was asked about speaking to the group because I'm employed by a hospital, by a university, as are a number of physicians these days, and the number continues to grow. And the number dramatically increased during and following the pandemic. So according to recent studies, as much as 74% of physicians are now employed either by a hospital, a healthcare system, a university, or a large corporate entity, 52% of which are employed by a health system, and the other 20% would be employed by a venture capitalist group. And that number increased by 11% just in a recent 2-year span during the pandemic. And there was reasons for that, but I think a lot of physicians were looking for job security, and that is often what the hospital can offer them. So as I mentioned, 72, if we can go back yet, 74% of physicians in our hospital are corporate employees, with the pandemic fueling the increase. And so I think that the independents and privately owned groups still have a very important role, but the majority of the people on this call, 75% of you, most likely will end up working for the hospital or for a corporation or for a big corporate-owned group. So what is autonomy? Christian asked me to speak on physician autonomy. Before I define physician autonomy, I think we need to just take a look at the word autonomy. The right or condition for self-government. So in the hospital setting, for self-determination. And you need to have capacity to have autonomy. So in order to be autonomous, you have to have the capacity to make decisions. Your object of your autonomy should always be morally righteous and really in the best interest of the patient and everyone around you. The person's own ability to act on their values and their interests shapes their autonomy. And the concept of autonomy has existed since the ancient Greek times. It's a modern political thought. I think it's a word that is used very commonly, and it's important that we all promote and respect autonomy. Well, before we speak about physician autonomy in healthcare, I think patient autonomy overrides everything. The patient's autonomy is more important than the physician's autonomy, the hospital's autonomy, the healthcare system's autonomy, the nurse's autonomy. When you walk in that room as a future physician, everyone will have autonomy, but we need to be respectful of everyone's choices, and especially the patient's choice and their right to make competent, informed decisions if they have the capacity to do so. As the physician, you want to have the freedom to determine the conditions of your practice, the healthcare delivery, with the principal goal of delivering and promoting the patient's health and well-being. So with that, I was asked by the BRI to speak to the group about what physician autonomy looks like in my practice and being hospital employed for 20 years and how it's worked for me over the years. So let's go to some of the questions that was proposed to us. So how much say do physicians have in the hospital setting? I think we have quite a bit of say. I mean, the physician is still, in my mind, the captain of the ship. You're the person with the largest amount of education in the room. And excuse the expression, but when shit hits the fan, people certainly are looking at you for guidance, and they want you to make those decisions. When things are less pressured, calmer, and in a more day-to-day basis, there's a lot of people making big decisions regarding the patient care, including nurse practitioners, advanced practice providers, PAs, nurses. So I do think still, though, that the physician is the leader of the team, and I think we'll speak later to who's on the team. But you have to get involved, you have to stay engaged, you have to have a voice, and the way you do that is really by partnering with the hospital and getting involved so that voice is heard. It was mentioned that you would hear about physicians looking for autonomy of voice, and how do they pursue things in the outpatient setting, and is it possible in the inpatient setting? I think it's important to look really at both worlds, the outpatient and the inpatient. For someone who's hospital employed, you might be in the hospital, and in one building, you're in the outpatient setting. You walk down the hall, and now you're in the inpatient setting. The lines are being blurred more and more, so it's hard to really distinguish. And oftentimes the leadership in the healthcare system is the same and has domain over both the outpatient and inpatient setting. But the way you have a voice is by behaving professionally and working hard and leading and being engaged and having a busy practice. So if you're a busy practitioner and you're seeing patients, 5 days a week the way I do, I think that the healthcare system and the hospital setting, in my experience, has always been very interested in your voice and what you have to say. So how do insurance companies and insurance policies interfere with the physician's autonomy and what they believe in to be what's in the best interest of the patient care? That's a tough one. And I think that that's a balance. So as I mentioned, there's a lot of players in that room. And one of the most difficult decisions you'll make as a physician is trying to balance everybody's needs, the patient's needs, the hospital's needs, that's your employer, and then the insurance company. So it's not uncommon that you're going to get a call from an insurance company, or maybe you might need to speak to a medical director there and do what's called a peer-to-peer. So usually everybody's in perfect alignment, but there's times maybe that there's disagreement. Maybe the insurance company doesn't want to approve a CAT scan or maybe a medication, and it seems like you're at an impasse. Well, that's when you could request a peer-to-peer review and ask to speak to one of the physicians that's employed by the insurance company. And if you can come up with justification, rationalization, maybe cite an article on why you feel this drug or this test or this surgery is in the patient's best interest, and really advocate for your patient. So as a physician, you're the patient's advocate. And sometimes you do have to really fight with the insurance company and even the hospital. Most of the time, everyone's in alignment, but there will be times that there'll be disagreement. And it's no different than any other industry. And there's times when you have disagreements, you have to handle those disagreements professionally, timely, and passionately. What does autonomy look like in the hospital setting? When you're in the hospital, there's a lot more people involved. When you're in the outpatient setting, you might be sitting in the room with the patient and perhaps their caregiver, their spouse, their son or daughter, and you're going to partner with everyone in the room in trying to optimize the care of that patient. When you're in the hospital setting, there's going to be maybe more than one physician caring for the patient. There's going to be consultants. So I work as a surgeon. Maybe the patient has an infection and I have an infectious disease colleague that I'm going to talk to. The patient might be in the intensive care unit, so there's going to be a group of physicians in the intensive care. If you're working at a teaching hospital, you're going to have fellows and residents that are going to be on the team. More and more, there's advanced practitioners, practice providers involved on the team, and I think we'll speak to what the team looks like. But the autonomy is still there if you're willing to lead. If you're not staying involved in your patient care, others will step in, and there's times that that's appropriate, and there's times that you really need to stay in charge of the team and of the patient's care. Can you share an example of how you use your autonomy in the hospital setting to advocate for a patient? Yes, I would say almost every time we have a patient that's in the hospital who maybe is having some issues, perhaps there's been a complication, that's really the time where you need to assert yourself as the captain of that ship, of that patient's care, and advocate for the patient. So to speak to a specific example, again, maybe the insurance company denied that CAT scan that you feel is necessary, or perhaps they want the patient to go directly home and you feel that's not appropriate. You want them to go to a skilled nursing facility or a rehab facility. So that's when you might need to pick up the phone and speak to someone on the other end, perhaps at the insurance company, explain to them why you feel it's in the patient's best interest to go to that rehab center and get the care that they need. Maybe they need to have some special medical device. Perhaps they have an open wound and they need to have a wound vac, and the insurance company doesn't want to authorize that. You have to explain to them and come up with a justification on why that's important. And it's not just you. You're going to partner with your social worker. You're going to partner with the inpatient team. You're going to partner with the nursing staff and really try to work together and assess what the patient's needs are before discharge, and then try to figure out how you can deliver on what the patient's needs are. How is the life for a physician working in the hospital setting with staff, nurses, mid-levels, changing all the time? I think that's something you have to get used to. When you're in the outpatient setting, there's going to be some consistency with the people you're working with, the nurse, the clinic manager, the social worker, etc. When you're in the inpatient team, depending on what floor your patient's assigned to, whether or not they're in intensive care or a step-down unit, and a lot of the consultants will rotate. So the faces are changing every day. And what I see happening in the hospital is there's often what's called a huddle, like what occurs in football. So people will huddle in the morning, people that are invested in the patient's care, and introduce themselves. I think introductions are very important, so everyone on the team feels that they're connected and they have a voice and an opportunity to speak regarding the patient's care. It probably doesn't change every day. I see it changing more from week to week or maybe month to month in the hospital setting. In the clinic setting, things are going to be a little bit more stable. There's going to be more consistency, but even there's going to be change. During the pandemic, there was a tremendous amount of people that left healthcare, both physicians and nurses, and a lot of new faces coming and going. One thing that you might see is people that travel, what they call a traveling physician or a traveling nurse. And these are people that maybe are employed by an agency, what people know as a temp agency, and they're temporarily employed by the hospital, but then they move on once their tour of duty, maybe it's a 6-8 week assignment, has been completed. They'll then go on to the next setting. So I think you need to be prepared for that. You need to be flexible. I think for young people, you're used to doing that. Think about every time you change classes, you have a class where maybe there might be 10 professors teaching one course, and things are done more and more collaboratively these days by the system rather than just the individual. So what does the physician team look like, and who's on that team? There's going to be a physician, either a medical doctor or doctor of osteopathic medicine. Oftentimes, the second person will be what's known as an advanced practice provider. These are providers similar to physicians that don't have a doctoral degree, but they have advanced degrees beyond nursing. So a nurse practitioner, a physician assistant, may be the highest member on the team, especially in rural communities, especially in the outpatient setting, or they may be the number 2 person on the team, but they're the person delivering the day-to-day care. They're there 5 days a week, and they have a lot of consistency with the staff in the hospital. So they know the nurses, they know the social workers, they know the pharmacists, and they're very familiar. So they're often the go-between between the physicians and the nursing staff. Many of them come from a career in nursing and really have that bond with the nursing staff and the trust with the nursing staff, and are really a vital part of the team. When you look at the nursing staff, you'll have what's called a charge nurse. That maybe is a nurse on that unit, along with other nurses that are delivering care. And then nurses have assistants similar to physicians in the form of nurses, aides, and medical assistants. So the teams can get pretty large. It's not uncommon at a teaching hospital, you'll see 10 people rounding together in the morning on the patient, and that team is composed of physicians, advanced practice providers, nurses, medical students, fellows, residents, pharmacists, social workers, and others. So it's really an impressive group of people that work together to deliver the healthcare in the hospital setting. What are the things that you expect more during the day-to-day life at the hospital versus the outpatient? I think some people like the simplicity of the outpatient setting. Let's say, for instance, your office is in the community. Now, you can literally pull your car up to the hospital, to the outpatient clinic, walk in the front door. Or many physicians like to walk in the back door because they don't want to walk through the lobby. They want to come in the back door and get started and not get bogged down by interactions that kind of happen ad hoc as you're walking in the office. And you're going to go through the day, maybe working with one or two medical assistants that are assigned to you, and maybe have a nurse that's overseeing the entire clinic, along with a clinic manager who's usually someone who has a business degree, who doesn't have a degree necessarily in healthcare. So it's just a lot simpler. If you own the practice, then that's going to look one way. If the hospital owns the practice, then that will look another way. But I think from the patient's perspective, they look pretty similar. The patient's going to come in, enter through the waiting room, be moved then to a patient exam room where they'll be interviewed, examined, and then they check out. So the throughput in that healthcare setting looks pretty similar. When it's owned by a hospital or a city or maybe a state, we call it the clinic. Most physicians will call it their office or their practice. If it's privately owned, it's the same idea, just slightly different delivery methods. At the hospital setting, it's going to be a little bit more complex. You're probably going to park in some parking garage. You'll walk across some bridge that goes over a street into the hospital. You might make rounds on your inpatients quickly and then head over to the outpatient setting, see patients. And while you're there, you might be taking calls from the hospital all day long. You might make some rounds during your lunch hour, or maybe even see a patient if it's urgent enough. I think more and more physicians are trying to separate so that they can stay dedicated to the patients in the outpatient setting. I remember growing up, when I was a patient, you would go see the doctor in the office. There'd be no appointment time. You would be sitting in a waiting room. And when the doctor got back from the hospital, the outpatient hours started. And there was a concept of what we know as triage, which in triage is a way of the most acute patient getting the greatest amount of attention and getting attention first. So it's not who's first in line, it's who is the most acute or who needs the greatest amount of attention. That might be in that individual patient's best interest, but that's not necessarily in the best interest of someone who had to take time off from work or away from their family to come see the physician. So I think more and more healthcare systems are recognizing the importance of the patient's time and trying to pay respect to that. Well, speaking to private practices, I have never owned a private practice. I've never been in private practice, but certainly I interact with a lot of private practitioners. Our hospital is a closed staff. So anybody who works at my hospital or works at any of the hospitals I have privileges at are hospital employed. So at the Veterans Association Hospital, our county hospital, our university hospital, what I mean by a closed staff is everybody who is there works for that healthcare system. Now, out in the community setting, you might have a blended environment where there's people who are hospital employed and people are employed by a private group. The people who tend to be hospital employed tend to be most of the emergency room physicians, the pathologists, the radiologists, the hospitalists, and many of the people in the intensive care. So the people who are working in the hospital, day to day, 5 days a week, they tend to be employed by the hospital. Where a lot of the surgical subspecialists and family physicians might float between the outpatient and the inpatient setting. And so they're not hospital employed, they're privately employed, but they work at that hospital. And that hospital might have what they call an open staff, where you can apply for privileges at the hospital. And you might be employed by a private group, or you might be employed by the hospital group. There might be two groups in, say, cardiology, and one is employed by the hospital and one's privately employed. And that works well as long as there's balance and both groups are being treated equally and fairly. I think sometimes there's a frustration if one group, either be in the hospital group or the private group, say accounts for 80% of the physicians in anesthesia, say for instance, then 80% of the resources from the hospital may be going towards that group. And that's where sometimes there could be a disagreement among the groups. And I think that's where this question is getting at. In terms of benefits, I think you benefit even in the private group if there's marketing for that hospital, if the hospital has a very strong reputation and a lot of history in the community, and you have the privilege to admit patients to that hospital, you're going to benefit from the reputation of that hospital. So hospitals are very careful about who they allow privileges to, because if the patient has a bad outcome, and that's directly related to the care the physician provided, indirectly it's going to reflect negatively on the hospital. So when physicians speak about having privileges at the hospital, that means your ability to admit a patient to the hospital and care for the patient at that hospital. So it's really a very important partnership, and probably something that people don't understand enough about. So this is just a fun slide that I put together recently. I'm going to step away real quick and just turn my light on. The sun just set here in Colorado.
Those are great quotes, by the way.
Okay, so you guys have had some time to absorb those quotes. And this is something I hear a lot of when I sit on different committees at the hospital. As Cleumy mentioned, I've been the president of 2 major medical societies. I sit on the educational board for 2 scientific meetings that I'm very involved in. And something that I hear people mention a lot is if you're not at the table, you're on the menu. And you can see the related authors there, everyone from Benjamin Franklin to Alexander Hamilton, to Marjorie Taylor Greene, Robert Kennedy, AOC, Kevin McCarthy, Lauren Boebert, Hillary Clinton. So a lot of people use this expression. Elizabeth Warren is given credit for being the first one who came up with this expression, but I think the expression is probably much older than that. But another way of looking at it is never beg for a seat at the table if you can build your own table. So I think those are the 2 worlds, right? If you're not at the table, you're on the menu. If you're hospital employed, it's really important to have a seat at the table because you will be on the menu. And if you're not at the table and you don't have a seat there, then maybe someone in your group does, one of your partners, one of your colleagues. But you want that representation, just like all of us want representation, in this world, so we have a voice. If you're on the menu, what does that mean? Well, it means that to some extent, people may be making decisions that really affect the day-to-day care that you provide to patients. And if you're not involved in those decisions, you may not be able to properly advocate for what's in the best interest. So let's say one of the decisions that's being discussed in the boardroom is maybe we don't need as many nurses in that unit or in that clinic, or maybe we don't need as many physicians on the hospital staff. we're going to cut staff in order to make a business decision, right? Then who's going to advocate for the physician, for the patient, for the nurse? That's what I mean by having a seat at the table. Now, sometimes there's an impasse and you feel that maybe you're at the table, but you're not being listened to. And the quote in the lower corner, never beg for a seat at the table when you could build your own. I think that may be what some people decide to do. I know one of the big followers of the BRI is the Oklahoma City Surgery Center. So I believe those physicians in Oklahoma City decided to have their own surgery center because they were frustrated with the high costs that they saw that was occurring in their community, especially for patients that were uninsured. They were trying to come up with a way for uninsured patients and underinsured patients, and really all, that they can deliver the healthcare there in an affordable way. So they decided to build their own table, and you see orthopedic groups very commonly build their own practice in their own buildings. Urology practices are doing this, and there is physician-owned hospitals throughout the country. And I think there's a decision that needs to be made for the 25% that aren't hospital employed, that they're starting to pool their resources and share resources in order to have representation. Maybe not at the table they thought they'd be seated at, but maybe they're being seated at a different table or building their own table. Certainly nurses have recognized this. This is an article in one of the recent nursing journals. If you're not at the table, you're on the menu. And so I think nurses have been very powerful in recognizing this. If you say, who is the hospital is really the nurses, right? That's the great majority of people that are caring for patients in the hospital are not doctors, not physician assistants, but nurses. And a lot of the nurses move up into hospital administration. Many of them get advanced degrees and business degrees and really represent the interests of the hospital. And indirectly, they have occasionally some conflict with physicians. That's another talk that we can do in another day. But I think they recognize the importance of having a voice in healthcare. Nurses are more likely to be part of a union than physicians. So it's not uncommon that unions come into a town and try to unionize the nurses. And that may be something that's in their best interest, or maybe it's something that's not. And is it in the patient's best interest? But they certainly understand organization. They understand getting involved and being on committees in the hospital setting. So getting back to having a seat at the table is not exactly a new expression. You can go back to the Gospel by Luke, and a quote from Luke is, when you're invited, go and sit down at the lowest place, so that when who invited you comes, he may say to you, friend, go up higher. Then you will have glory in the presence of those who sit at the table with you. So what does this mean? It means to be humble, right? So when you take that seat at the table and you're new to the group, maybe sit there and just observe, take it all in, learn how the process works. Before you are a good spokesperson, you need to be a good listener. You need to understand what are the different issues and try to approach it from a broader perspective, and try to understand the needs of everyone at the table and put yourself in the other person's position and try to understand what those needs are. And I think if you can do that, you'll gradually move to a higher seat at the table, and which will indirectly benefit your patients. So let's finish up here, maybe do 10 minutes of Q&A here at the end. Get involved, stay involved, join hospital committees, look for leadership positions, in your group. And I think it's all very doable. It's something that I've done in my career. I've sat on a number of committees, and I've really benefited tremendously and learned a lot about the healthcare delivery. And I feel that I've been able to have a bigger voice and be able to really make a difference in the lives of my patients by staying involved and staying close connected to the hospital. Some people will be employed in a private group, some will be employed in the hospital, and that may change over the course of your career depending on what your needs are, interests in. But they're both great systems, they both work. I think that as physicians, young physicians coming up through the ranks, you can get involved as a resident in leadership positions, you can get involved as a fellow, and organizations are always looking for new voices that come in the organization and bring new ideas. So thank you for giving me this opportunity. And let's go to the Q&A.
Well, thank you so much, Dr. Flynn, for sharing all those things. I for sure loved your definition of autonomy, how you clearly presented that, and how special it is that you highlighted also humility for us physicians in training, whether medical students and residents, wherever we find ourselves in, soon to be attendings, the importance of humility in all walks of life. Thank you for sharing all those things. I think we're keeping an eye now for the chat to see if we have any questions. I don't see any at the moment right now, but I did have a few thoughts that I wrote down while you were talking. You brought so much about job security, the difference between private practice in the hospital, private practice outside the hospital, and just being a hospital employed directly. I think one of the things that I thought of is, do you see, maybe not for your group or where you're working, but overall, I don't know if you, as you talk to other physicians about pressure to reach milestones or performance marks that is imposed on physicians, that they may conflict with whether patient autonomy or just the overall caring for patients. When, let's say, you need to see X amount of patients per day, you don't give them the attention that you will like, but you have pressure from outside sources to reach milestones or things like that.
Yeah, that's a great question. I think how many patients do you see a day depends a lot on what you do and the complexity. So some physicians might see 10 patients a day if they're extremely complicated patients. Say a physician who's a transplant physician. There's a lot of medical issues and a lot of social issues that one would need to consider. Maybe you're an oncologist and you really have to take a deep dive into all of these issues. As a family physician, I don't think it's uncommon to see people see 30 to as many 50 patients in a day, but a lot of the problems are less acute. So someone might come in with 3 problems, and it's not uncommon that they'll say, well, we can talk about one of them, the one that matters you the most, and let's bring you back, say, for the other, problems to discuss. So there's going to be pressure, and the pressure usually comes from within and your desire to help people. So maybe you have 20 patients on your schedule that day, but during the course of the day, you get calls from 3 of your referring physicians of patients they want seen that day. And then your patients might call or send an electronic message with an acute problem that want to be seen. They don't want to go to the emergency room, urgent care, and that 20 patients might balloon into 30 patients. So the pressures to see patients sometimes come from within, whether you're in a private group or you're an employed group. There's a unit called the Relative Value Unit, RVU, which is a unit they use to track the amount of work, essentially, that a physician does. And in a lot of private groups, it's fee for service. Other groups will reimburse physicians based on the number of RVUs they create. And then maybe in a hospital employed model, they might have a set salary. But even in the hospital employed model, people are still watching your RVUs in order to make sure that they're getting good value for their employment. So the hospital needs a metric to compare you to maybe your colleagues to see if you're, working at the level that they seem appropriate. These RVU levels are something that are published nationally that hospitals can use to compare a urologist in Colorado to a urologist, say, in Utah or in Virginia or in Texas. And they use those value units to base your physician salary. So I would say that the pressures are going to be there. Where the pressure is coming from might be different based on the practice setting, but whether you're hospital employed or you're privately employed, there's always going to be a pressure to see more patients, which kind of bleeds into what we call work-life balance, right? We all have families and we went into medicine to care for people, but we also have people at home that care about us, and then we care about them and we want to spend time with them. And how do we balance that? And how do we have boundaries? That's where I think trying to utilize advanced practitioners in your practice and growing the size of your group. I hear a lot of people that are in solo practice. Maybe they're on call every night, or maybe there's two people in the group, so they're on call every other night. Most hospitals have bylaws on what they would consider safe and reasonable in terms of the amount of call you can take. And that's usually not any more frequent than every fourth night. So someone might move to the hospital setting because they'll say, I don't want to be on call every night. I want to be on call every fourth night or every fourth weekend, or however that works out. But you'll be on call, say, 25% of the time, no greater, if you're in the hospital model. If you're in a private group, you might be on call every night if you're a solo practitioner for your practice, right? But that doesn't mean you have to see every unassigned patient that comes into the hospital. So in the ER, there might be, say, 10 groups that are rotating through, call for new admissions, say, in primary care. So maybe every 10th night you're on call for unassigned patients, but you're on call every night for your own group. And typically you'll have a call center where that first contact will go, and then the call center will call you, and then you'll call the patient back or the provider back. But those are complicated things, Cleumy. I would really stress to the students that when you're finishing up with your residency, to really look at those things carefully, because that's really going to make a big difference in your overall quality of life.
That's for sure. It's funny you were talking about this work-life balance, and that was one of the questions that I see here in our chat, talking about work-life balance. And I think for us, where we are right now, it's more, we have been working so hard for so long, and then we're going to be working perhaps even harder during residency for so long. I know it's limited, your time in residency, depending on what you do, but you work really hard. And how do you have any advice as physicians who are coming out of residency? I know you're just touching on that point, how to approach this work of life balance, advocating for yourself, advocating for your patients who can only take as much care of patients as you're taking care of yourself. How should physicians or coming in residents, becoming attendants, look for this work-life balance?
I think you have to understand what your own interests are and how much time you personally want to dedicate to your profession. There's some physician practices and specialties that maybe allow better work-life balance since they're more outpatient based and the patients are less acute. I'll give an example like dermatology or ophthalmology. There's just less emergencies. If you choose to be a cardiothoracic surgeon, a transplant surgeon, an interventional cardiologist, there's going to be emergencies. And there's going to be time where you are needed and no one really can fill in for you. So you have to make that decision at a young age when you're choosing your residency, and that's very hard. So I think that's where mentorship is important. Oftentimes there'll be a lunch talk where someone from a certain specialty will come over to the medical school, speak to students, and you could ask them, hey, what's your life like? How many hours do you work? What time do you go to work? When do you leave? Do you get a chance to work out? Do you get a chance to see your family? Do you get to go on vacation? But I think it really comes back to Benjamin Rush, right? And, the old school physicians, the Marcus Welby, that medicine really needs to be a calling. If it's not calling you, you probably want to run away right now. And you don't need to waste your MD or DO degree. You can get a job in industry. You can work for an insurance company. You can still be employed and do very well, but maybe not as a physician because you're just not willing to put in the time. The amount of hours you'll work as an intern and during your chief resident year, your fellowship year, and your earlier years in practice, that might push 60 to 80 hours a week. Okay, they've put caps on how many hours you can work and on the 80-hour work week in order to allow patient safety, but it's going to be a lot of time. And you really have to make sure that you're partnered with the right person. If you do have a significant other in your life, that you have the support from them, you have the support from your parents, and you have an outlet. Physician burnout is something that people look at very commonly. And if you get burned out, you're going to pursue self-destructive behaviors, right? Alcohol, drugs, things that really are only going to put you further downward in that spiral. So you have to have healthy outlets. For me, it's fitness. I like to work out, and that's a healthy outlet. My family is a healthy outlet. We like to do a lot of things together. Hobbies are going to be important in maintaining hobbies, and probably most importantly is maintaining the relationships you have with your friends and family while you're going through it. Because if you miss that wedding that you're invited to, if you don't go to that funeral that you really should have gone to, you're always going to regret those things. So you can't sacrifice yourself completely because there'll be nothing left to you, and then you won't have the ability to take care of patients. It's been shown that physicians who are burned out lose their ability to have empathy. If you lose your ability to have empathy, you're not going to be a very effective physician. So you have to really keep your eye on that and have others look out for your well-being. But it's very doable, Cleumy. I don't want people to think that this is overwhelming. Anybody who's gotten to the point where you're at and other students are at, you've already gone over a bunch of big hurdles. And it will continue to be hard, but it'll be very well worth it. It'll be very rewarding if that's truly your calling.
That's what I hear from upperclassmen. It gets better. Somehow it gets better. We came so far, it gets better.
And I'll close on this. Where it gets better, the older you get, is having more control over your life. So maybe You're going to have a crazy busy week, but you anticipate, say, something coming up, and there's some event you want to get to, a birthday party, your kid's game, a vacation, a dinner party. You have to plan ahead. And the more senior you are, the more control you have over the schedule. And you have to plan to not be on call or plan to have a lighter day in the clinic. I think people who own their own practice, that's probably one of the most satisfying things that they tell me, is that they have that control to be able to pull back at the times they need to and go hard when they have the time to do that. And that's the balance. And getting back to autonomy and self-determination, those are the things that bring happiness. When you feel you have no control over your life and you feel that some puppet master is controlling you, that's when you're going to get frustrated and get angry, and you have to recognize that in yourself, and at that point look for opportunities to be able to reach out to your mentors, reach out to your loved ones, and try to get the support so you can reset.
Absolutely. You have shared with us so much truth that I'm sure we're going to have to be rewatching this recording a few times to be able to truly digest all the truth that you have shared. And we truly appreciate all your advice and guidance and wisdom. I want also to be respectful of your time. You're reaching over our time limit now. And once again, I just wanted to thank you, Dr. Flynn, for your presentation, for being open to chat with us, with medical students. And it's so nice to hear such things, that it gets better and that we can, there's so much to enjoy also. There's, yes, a life of sacrifice. We're sacrificing a lot of things, but there's so much to enjoy also. Many blessings in medicine, as you said, if that is our calling. So, sir, thank you so much. We appreciate all that you shared. And if anyone has any more questions, we have our email from our Director of Programs, chris@benjaminrushinstitute.org, that you can email with questions or anything that you would like to know. And with that, we'd like to close our virtual event series for today. And we're looking forward to seeing more people next month.
Cleumy,
Yes, sir.
one last thing. I think that for the BRI, any of the students here that are participating really should start following you guys on your social media accounts. Give us a thumbs up. Start following some of the people that are the thought leaders, because I think we need to get the word out. And the way we do that is by doing what we're doing tonight. You know, we don't have a large group tonight, but the number of people that will watch this in the future will be a lot more people that are attending tonight. And the way we can get that traffic moving on YouTube or on Twitter or on Instagram or any of the other accounts that you guys are active in is have people sign up, have people follow, and have people give us a thumbs up. And so thanks again for the opportunity. I really appreciate you guys. I enjoyed getting to know you, Cleumy and
Likewise.
Christian, Richard. Thank you guys, and we'll talk soon.